yes. So my topic is very specific as to what happens when the capsule gives way after you implant an IOL. So to start the case, I have two cases very similar just to understand and bring about the point that we want to make in this presentation. So this is a patient with a classical posterior polar cataract, and our choice for surgery in polar cataracts has been, if the patient does accept it, to undergo a femtosecond surgery. And this technique of ours is published. It's called femtodelineation, where we do not make any chops, but we make rings so that these things can be easily picked out. Once the surgery is done, chances are our rupture rates are really low with this sort of technique. But notice that when we're implanting a lens into the eye, there is a slight mismatch between the IOL and the incision size. And notice how the IOL dips and gets stuck at the incision. Once the IOL is stuck, and particularly these lenses when they're stuck at the incision right in the center, it's very difficult to pull them out or push them in. So best thing to do is to try and enlarge the incision, trying to make sure that the optic doesn't get damaged or scratched because of this. But notice while all this maneuvering was happening, the posterior capsule, because it probably was inherently weak due to the polar nature, has already given way, and there's a large PCR lying over there. This can also happen when the IOL shoots inside the eye, and this is not very uncommon, can rarely happen. The idea is, first of all, to salvage that posterior capsule ragged tear into a more sort of a curvilinear situation, so that when you're doing any more maneuvers, the capsule doesn't give way and it doesn't become a full split where the eye cannot be salvaged anymore and the IOL has to be explanted. So here we are trying to use these microforceps to convert that ragged tear into a relatively rounded capsular axis. And once that's done, I think the next thing is to understand how much of the anatomy inside has been distorted, and to understand that the first primary thing to do is to close off the main wound, because number one, it's an enlarged wound because we've enlarged it. It's more than a 2.2 or a 2.4 wound because we had to enlarge it to be able to push that lens inside the eye. Now, it is easy to make out that there is vitreous inside the eye because the vitrectomy is because the vitreous presented because of the PCR. Our choice of handling such situations is now shifted from a limbal vitrectomy over the last few years into a total pars plana approach. Again, we are trying to see under irrigation and low bottle height to convert the other edge on the distal side and pull back that little flap that was there, because the moment we start vitrectomy and the vitreous catches this posterior capsule, it can also be a problem. Staining now done shows very clearly how vitreous is presenting to the wound. So with the limbal irrigation on the left hand and a vitrectomy in the right hand through the pars plana, which is at 4 millimeters, 3.54 millimeters behind the limbus, we are trying to approach the vitreous from the bottom or from the natural compartment of the vitreous cavity and trying to pull it back into its compartment. Rather than doing a limbal vitrectomy, the parameters here are to have the highest cut rate possible and a very low and a moderately low bottle height, so the chamber is maintained, and an appropriate flow rate. The idea is not to do a core vitrectomy. The idea is just to clear off the area of it within the area of the PCR and a little beyond. And once we go ahead with this, it's the vitreous that is presented anteriorly also tends to prolapse back. As you can see over here, the vitreous which is presented anteriorly and is stuck with the IOL also tends to prolapse back. Whatever is stuck in the front of the IOL will be guillotined off. So if you notice, the remaining vitreous which has been cut off from the posterior vitreous body can then be handled via the limbal route. And this is exactly what we're doing over here. To understand the difference between a limbal and a pars plana approach, when we do a limbal vitrectomy, the vitreous cutting and the vacuum causes an upward drag on the vitreous body. So typically a PCR that was small tends to enlarge, and what was a small PCR becomes a non-salvageable one. On the other hand, so this is just to show you limbal vitrectomy, and notice the area of the PCR, the extent of the PCR over here. But the moment we continue with the limbal vitrectomy, you notice how the whole vitreous body tends to tent up and down, and it tends to trampoline. And at some point, the edges which are sharp will open up like a zipper and cause an enlargement. If your posterior PCR enlarges beyond a certain size, you'll not be able to convert it into a capsular axis and may not be able to implant the right lens in the eye. On the other hand, if you do a pars plana vitrectomy, you are pulling the vitreous back into its natural compartment, as we saw in the patient surgery previously, and thereby chances are that your PCR, even if it enlarges, can still be converted into a capsular axis because it will not pull upwards. Again, to show you how tranquil it looks on a high-speed photography. So this has been captured at a very high frame rate and it's being played off very slowly. So you can see the vitreous cut and the vitreous moving down. And you can also see that there's no turbulence in the anterior chamber. So once this is done, we wanted to visualize what has happened to this patient's eye, and so we've put iris hooks to pull back the iris. As you can see over here, it looks like it's a well-rounded capsular axis, posterior capsular axis on this side. Just move ahead. Yes, so the IOL can now be dialed into place because we now know that there is no vitreous presenting in there is no vitreous engulfed with the IOL body, and so now safely, now that you know that there is nothing that can be pulled up and there is no traction and no posterior capsule that can split up furthermore, the IOL can now be dialed into the capsular bag. You notice those two sharp edges over there, and that's because of the blade, but fortunately it's not in the visual axis, so it should not disturb the patient too much. But the idea is now is to go very slow and make sure that you leave the IOL right in the capsular bag itself. I'll move ahead to show you. This is how the patient looks post-operatively. It's a well-centered IOL, and that's the area of the PCR converted into a PCCC. I'll just briefly show another case, a very similar case, again a polar cataract, and this time one eye has gone on well, and we are planning a multifocal lens for the other eye. Again, the technique here, we did a femto delineation technique, and we were able to save the bag, and the IOL goes inside the eye. Everything looks pretty normal, and this is, it's a very good situation that we were able to put a multifocal lens in the other eye, and it's a very well finished surgery. But when we were doing a bimanual IA, the idea is to remove the viscoelastic from behind the IOL. So irrigation is behind the IOL and the aspiration is in front. Sometimes you notice over here, in an intact posterior capsule with the aspiration in front of the IOL, the posterior capsule split up. That's probably because, again, it was an inherently weak capsule, as in a posterior polar cataract. So the surgery is not over until you've pulled out your instruments and hydrated and packed out the eye. And now there's a multifocal lens inside the eye, and the IOL is decentered. And you can see the peaking here at the posterior capsule. Triamcinolone staining, which I think is of paramount importance, and all of us should use triamcinolone when we land up in sticky situations like this, shows us very clearly that there is vitreous in the anterior chamber. And now there's a multifocal decentered lens. We tend to use dispersive viscoelastics to stabilize the anterior chamber. And again, like I said, the technique for us is a pars plana vitrectomy. So if you don't have access to a 23 gauge trocar cannula system, you can use an MVR and just open up the conjunctiva and enter and suture it back, because it's important to save the eye at this moment. Again, if you notice, the posterior cutting forces will drag the vitreous body from anterior back into its natural compartment. And this is a very beautiful video showing exactly what we were trying to show in the animation, is that if you can understand and work with the anatomy of the eye, you can make sure that the PCR doesn't enlarge. And this is even more important in this eye because it has a multifocal lens, and we really hope to put it back into its place. So this is how it's done, and whatever little bit is remaining behind can be tackled through the anterior route. Again, a very well stabled lens, even a 3 months follow-up, and this is principally because we were able to go posterior and make sure that we don't worsen an already worse situation. This is just to show you UBM, again a very well stable centered lens because it's in its natural compartment, and which is the capsular bag, and hardly any aberration profile. Again, because it's a centered lens, because we did a good vitrectomy all around. So just to finish off, surgeries. So this is a situation that I think we must never face. Again, a polar cataract, and everything went very well. And like I said, the surgery is not over till it's over. And this is one of the best examples of how it presents. And I want you to pay attention now. And what a beautiful video, but fortunately there was no vitreous, and we had left the patient like this. Needless to say, please have the patient undergo retinal evaluation, because this is a situation of compromise, and whatever best we do, retina can still be damaged, and not only the central retina but also peripheral retina needs to be done very well. Evaluation. Thank you so much.
Thank you, Dr. Samaresh, for that excellent array of cases, and how you could still manage to maintain that single piece in all of those single piece IOL in all of the situations. Dr. Samaresh, there's one question that always comes to my mind when we talk about limbal vitrectomy and pars plana, is that there's a fear amongst us as cataract surgeons that if we go through the pars plana, we are more likely to cause retinal breaks more than limbal route. Or what's your opinion on that? that?
Yeah, I think, Shal, that's a great question. I have two arguments to this. One, if you do a limbal vitrectomy and you're not able to do what you're supposed to do, is put the right lens in the right place, then your battle is half lost. And secondly, the situation is already compromised. So even if you're doing a vitrectomy, you are causing a drag on the vitreous body and thereby maybe creating a tear. Chances with the limbal vitrectomy may be more. Even if you do, when you do a pars plana vitrectomy, not only do you clear the compartment, you create a stable scaffold. So your job is well done. And even if there is a break, the retina doctor with a good indirect ophthalmoscopy can pick it up and do a barrage around it and prevent things from worsening. So I think it's better to have the retina doctor look at it than try to do a limbal route and worsen the situation.
So I think the take-home message from that is that actually by approaching through the limbal route, we are actually causing more drag and more traction. And in fact, the chances of retinal breaks or enlarging the tear are more through the limbal approach than through the pars plana approach. So thank you, Samaresh, for highlighting that with that wonderful animation.